Hey guys, welcome to another episode of the Human AI podcast. Today we're going to talk about lung imaging and we are also going to talk about pleural and chest wall disease. I'm here with Krog. I'm going to ask Krog a bunch of questions about these topics and hopefully we can learn stuff. Take everything with a pinch of salt as always and hope you find it informative and enjoyable. Without further ado, let's get on with today's topic. Krog, are you ready?
Yo, I'm ready. Let's dive into lung imaging and pleural chest wall disease. Hit me with your questions and we'll unpack this stuff together. What's first?
Well, let's talk a bit about lung imaging first. So we have the usual suspects, X-rays, CT scans, and I kind of want to understand what are the benefits for each one, when do we use each one. Perhaps we can talk about ventilation and perfusion imaging too. Um, so yeah, do a small introduction to these ones, and then let's dive into one of them. As a general rule for the podcast, we say this nearly every time now. Grog, let's try to be as efficient and effective as possible with our conversation. Let's try to use the minimum amount of words that's going to get our point across, and let's try to be, yeah, direct.
Got it. Let's keep it tight and direct. Lung imaging. X-rays, CT scans, and ventilation perfusion, VQ scans, each have distinct roles. X-rays are quick, cheap, and good for initial checks like infections or lung collapse. CT scans give detailed 3D views, ideal for tumors, fibrosis, or complex infections. VQ scans assess airflow and blood flow, mainly for pulmonary embolism. Want to start with X-rays? They're the go-to for a fast look at the lungs.
Yeah, let's start with X-rays for sure.
Cool. X-rays it is. Chest X-rays are the first-line imaging for lung issues. Fast, low cost, and low radiation. They're great for spotting pneumonia, lung collapse, or fluid buildup, but they're limited for tiny lesions or deep tissue details. Taken in postero-anterior or lateral views, sometimes portable for bedridden patients. Anything specific about X-rays you want to dig into?
Well, there's some areas I don't even know what they are. Well, I kind of do, but like the apices. What is apices? APICES. How can I look at it in an X-ray?
Nice one. Let's clear that up. The apexes, pronounced AYPICES, are the uppermost tips of the lungs, right under the collarbones. On a chest X-ray, they're the topmost areas of the lung field.
Interesting. Well, okay. So, some things that, for instance, we can see from an X-ray is the heart, right? But how do I know that my heart
All right, so we were...
a good size? So do I do the cardiothoracic ratio?
Yeah, exactly. The cardiothoracic ratio is what you're looking for to check heart size on a chest X-ray. Measure the widest diameter of the heart and compare it to the widest diameter of the chest at the same level, usually from a postero-anterior X-ray. A normal ratio is less than 0.5, meaning the heart should be less than half the chest width. If it's bigger, it could suggest cardiomegaly, but you've got to consider patient build and X-ray technique. Want me to break down how to measure it step by step, or something else about heart assessment on X-rays?
That makes sense. So is X-ray a type of radiography?
Yep, spot on. An X-ray is a type of radiography. Radiography is the broader term for imaging using radiation to create pictures of the body. And X-rays specifically use ionizing radiation to capture images of bones, lungs, or other tissues.
So is CT scan a radiography too?
Yes, CT scans are also a form of radiography. They use X-rays like traditional radiography, but rotate around the body to create detailed, cross-sectional images. Unlike a standard chest X-ray, CT gives 3D slices, showing much more detail for things like tumors or blood clots.
So
Want to
is
dive?
all imaging techniques radiography or no?
Nah, not all imaging techniques are radiography. Radiography specifically uses ionizing radiation, like X-rays or CT scans, to create images. Other imaging, like MRI, uses magnetic fields and radio waves, and ultrasound uses sound waves, no radiation involved. Then you've got nuclear imaging, like PET scans, which use radioactive tracers. Each has its own tech and purpose. Want to focus on one of these or stick with
I
radiography?
see. So with radiography, so we said that we have ionizing radiation, which is kind of the downside, isn't it? But it's cheap and available, it seems, and also it gives us great spatial resolution. But how come it gives us great spatial resolution?
Yep, you nailed the trade-offs. Ionizing radiation in radiography, like X-rays and CT, is a downside due to small cancer risks with repeated exposure, but it's cheap, widely available, and delivers solid spatial resolution. The great resolution comes from how X-rays penetrate tissues differently. Bones block more, soft tissues less, creating clear contrast on the image. Detectors capture these variations sharply, especially in high-contrast areas like lungs or bones. CT amps this up by reconstructing multiple angles into detailed slices. Want to dig into how resolution compares to other methods or something else?
I want to ask why we have very limited tissue visualization with radiography.
Radiography, like X-rays, has limited tissue visualization because it relies on X-rays passing through tissues, which show up as shades of gray based on density. Dense structures, like bones, stand out, but soft tissues, lungs, muscles, organs, blend together since they have similar densities. This makes it tough to distinguish fine details or subtle abnormalities in soft tissues compared to CT or MRI, which offer better contrast and 3D views.
I see.
One
And what does it mean as a weakness of radiography that it's projectional?
Radiography being projectional is a weakness because it flattens a 3D body into a 2D image. Structures overlap, so things like tumors or fractures can be obscured by bones or other tissues in the path of the X-ray beam.
And we have any type that is of imaging technique that is not projectional?
Yeah, so we were saying projectional radiography flattens 3D into 2D, causing overlap issues. Non-projectional imaging techniques exist, like CT, MRI, and ultrasound. CT uses X-rays from multiple angles to create 3D slices, avoiding overlap. MRI uses magnetic fields for detailed 3D images, and ultrasound uses sound waves for real-time, non-radiative views. These give clearer, layered visuals of organs and tissues.
But I thought CT is also radiography, so is CT also radiography but not projectional?
You're right, good catch. CT is indeed a form of radiography since it uses X-rays, but it's not projectional like a standard X-ray. Instead of flattening everything into a 2D image, CT takes X-ray images from multiple angles and reconstructs them into detailed 3D slices, avoiding the overlap problem. So it's radiography with a 3D twist. Want to clarify more about CT or shift to another imaging type?
I'm a bit confused. Okay, fair enough. And so, basically,
No worries. Let's clear it up.
when something has high atomic number, like bones that have calcium and everything, this is gonna appear more white. What about water and soft tissue and fat and air and gas? What are the colors here?
All right, let's break it down. On an X-ray, the color, or really the shade, depends on how much X-rays are absorbed, which ties to the atomic number and density of the material. Bones, high in calcium with a higher atomic number, absorb more X-rays and appear white. Soft tissues, like muscles or organs, have lower atomic numbers and absorb less, so they show up as shades of gray. Fat is less dense than soft tissue, so it's a darker gray. Water, similar to soft tissue, is also gray, but can vary slightly based on context. Air and gas absorb almost no X-rays, so they appear black, like in the lungs or bowel gas. Want to go deeper into how these shades help diagnose conditions or something else?
No, that makes sense. That makes sense. So if we talk a bit about CT scan now, we said that it shows greater detail. It resolves small structures, and we can have spatial resolution, contrast resolution, and resolve small differences in attenuation. What do you mean with this? And why
Cool.
is this true?
Cool. Let's jump into CT scans. CT shows greater detail because it has excellent spatial and contrast resolution. Spatial resolution means it can distinguish tiny structures, like small nodules or vessels, down to a millimeter or less, thanks to thin, precise X-ray beams and 3D reconstruction from multiple angles. Contrast resolution means it picks up subtle differences in X-ray attenuation, so tissues with similar densities, like muscle versus liver, stand out clearly, especially with contrast dyes. This happens because CT measures X-ray absorption more precisely than a 2D X-ray and can enhance differences with
Wait.
computer.
So you're saying we go from 3D to 2D and then we reconstruct the 2D back to 3D?
My bad, let's clarify. With CT, we don't go from 3D to 2D and back. The body is 3D, and CT scanners take multiple 2D X-ray images from different angles around the body. Then, computers use those 2D images to reconstruct a 3D model or detailed slices, giving you clear, layered views without the overlap of traditional X-rays. It's like building a 3D
So a CT
puzzle.
is just a bunch of X-rays together.
Yeah, exactly. A CT scan is basically a series of X-ray images taken from different angles as the scanner rotates around you. Those images are then stitched together by a computer to create detailed 3D or cross-sectional views of your body.
Any
It's
new
like-
imaging technique with AI now?
Yeah, AI is shaking things up in imaging, especially for lungs. Deep learning algorithms are boosting chest X-ray and CT scan analysis, improving detection of things like lung nodules, pneumonia, or fibrosis with higher accuracy than traditional methods. AI can enhance image quality, reduce noise in low-dose CTs, and even predict disease progression. For example, tools like those from Stanford have outperformed radiologists in spotting pneumonia on X-rays. AI is also being used in VQ scans to better map lung function for embolism cases. Want to zoom in on one of these AI advancements or how they're changing diagnosis?
I'm asking specifically about a new type of imaging though.
Got it. My apologies for the mix-up. There isn't a brand new imaging modality replacing X-rays or CT for lungs, but AI-driven techniques are evolving existing ones. One notable advancement is AI-enhanced low-dose CT, which uses deep learning to reconstruct high-quality images from lower radiation doses, improving safety without losing detail. Another is AI-powered digital tomosynthesis, a type of enhanced X-ray imaging that creates quasi-3D slices of the lung, offering better depth visualization than standard X-rays, but with less radiation than CT. These are upgrades to radiography, rather than entirely new modalities. Want to explore one of these further, or shift to pleural disease imaging?
Well, it's all good. I want to ask you a bit about CTs more. So, the thickness, let's say I'm going to do a CT scan on the thorax. What's the thickness of each X-ray?
All right, let's talk CT slice thickness for a thorax scan. Slice thickness typically ranges from 0.5 to 5 millimeters, depending on the scan's purpose. For detailed imaging, like detecting small lung nodules or coronary arteries, thin slices of 0.5 to 1.25 millimeters are used, giving high resolution. For broader surveys, like checking for infections or large masses, thicker slices of 2.5 to 5 millimeters are common, balancing detail with faster scanning and less.
And since it's 2D, basically it doesn't have thickness, does it? We only have like space between the two X-rays.
I see where you're going. Good question. Each CT slice is a 2D image, but it represents a thin 3D section of tissue with a defined thickness like a super thin pancake, not a flat plane. The thickness, e.g. 0.5 to 5 millimeters, is the depth of tissue captured in that slice. The space between slices, if any, depends on the scan settings.
What the heck, dude? I thought it was 2D.
Haha, my bad for the confusion, dude. Let's straighten this out. Each CT image looks 2D on the screen, but it actually represents a thin 3D slab of tissue with a specific thickness, like 0.5 to 5 millimeters for a thorax scan. Think of it like slicing a loaf of bread. Each slice is flat but has some depth. The scanner captures these slabs.
You know, this is terrible what you are saying to me. You know, if we add the fourth dimension in our world, even it's infinitesimally small, we basically add a whole set of universes. So we create a multiverse just by an infinitesimally small fourth dimension. So you're saying to me that because our third dimension here is 0.5 millimeters, it's not worth mentioning and we're calling it 2D? What the heck, dude? Or didn't I understand?
Haha, dude, I love the multiverse vibe you're bringing. Alright, let's untangle this without opening a portal to another universe. You're right to question this, and I'll keep it crystal clear. When we say a CT image is 2D, we're talking about how it's displayed, a flat image on a screen, showing a thin section of your body, like a snapshot of one slice. But that slice isn't infinitely thin. It has a tiny bit of depth, called the slice thickness, usually 0.5 to 5 millimeters for a thorax CT. That thickness is the third dimension of the slab of tissue captured, but it's so small compared to the width and height of the image that we simplify and call it a 2D image for practical purposes. It's not that the third dimension doesn't exist, it's just super thin, and we're not ignoring it, but we don't emphasize it when viewing a single.
So we have a CT thorax, and it's got, let's say, these few millimeters slice thickness. So, and we also say we have a bunch of X-rays. How many X-rays do we take in a CT?
For a CT thorax scan, the number of X-ray projections depends on the scanner and settings, but modern multi-detector CT scanners typically take hundreds to thousands of X-ray images per scan. A single rotation around the chest might capture 500 to 2,000 projections, with the scanner rotating multiple times in a few seconds to cover the thorax. Each projection is a tiny snapshot, and the computer combines them to create the 3D dataset.
So let's say 2,000, and you're saying that from these 2,000, how many millimeters is the thickness of each one?
All right, let's clarify. The 2,000 projections in a CT thorax scan aren't each tied to a specific thickness. Instead, those projections are raw X-ray data taken from different angles during the scanner's rotation. The computer uses all of them to reconstruct a 3D volume of the thorax, which is then divided into slices. The thickness of each slice, like 0.5 to 5 millimeters, is set by the scan protocol, not the number of projections.
Bro, I don't understand. I'm so confused. What are you talking about? So the initial X-rays are 2,000, let's say.
My bad, bro. Let's make this super clear. You're right. A CT thorax scan might take around 2,000 X-ray projections. Those are like quick X-ray snapshots from all angles as the scanner spins around you.
So these X-ray projections, I think this is where I got confused before, guys. These X-ray projections, they don't have thickness.
Exactly. You're nailing it. Those X-ray projections in a CT scan are just raw data snapshots. like super quick X-ray beams shot from different angles.
And they are two-dimensional.
Yup, spot on.
Okay, so guys, forget my rambling from before. I got confused. I thought these were suddenly three-dimensional. Okay, so we have these two-dimensional X-ray projections. Let's say we've got 2,000 of them, and we put them all together. So when we put them together, we stack them upon each other. How do we do it?
Awesome, we're back on track. So, you've got those 2,000 two-dimensional X-ray projections from the CT scanner, each one like a flat snapshot taken from a different angle around the thorax. These don't stack like pancakes. Instead, the computer uses a process called reconstruction to combine them. Here's how it goes. The projections are fed into an algorithm, usually something called filtered back projection or iterative reconstruction. This math wizardry analyzes how X-rays were absorbed from all those angles to map out a 3D model of the thorax. Then, that 3D model is sliced into thin 2D images, each with a thickness you set.
Wait,
like
what? So we do the reconstruction, but then what happens?
All right, so we do the reconstruction with those 2,000 X-ray projections. The computer takes all that raw 2D data and uses algorithms to build a 3D digital model of the thorax, figuring out where tissues, bones, and air are based on X-ray absorption. Then, it cuts that 3D model into thin 2D slices, like slicing a loaf of bread, each with a set thickness, say 0.5 to 5 millimeters, depending on your scan settings. Those slices are the CT images you view, showing detailed cross-sections of the lungs, heart, or whatever. Want to dive into what these slices show?
I want to ask, so these projections, during the reconstruction, basically we kind of warp them to become three-dimensional, and we basically simplify how the rest would look by just making it the same.
You're getting close, but let's fine-tune it. During reconstruction, the computer doesn't just make the 2D projections 3D by guessing or simplifying. It uses math-heavy algorithms to analyze all 2,000 projections, how X-rays were absorbed or passed through from every angle. This creates an accurate 3D model of the thorax, mapping out densities differences for bones, lungs, tissues, etc.
Yes, but but between those 2,000 projections, there's gonna be things that we didn't see that we are not gonna show.
You're absolutely right. Good point. The 2,000 projections don't capture every possible angle or microscopic detail, so there are tiny gaps in the data.
So where is this slice thickness then? When we say slice, does each slice equate to one projection?
Nah. Great question though. The slice thickness in a CT scan doesn't equate to one projection. Those 2,000 projections are just raw X-ray data from different angles, used to build a 3D model of the thorax. The slice thickness, like 0.5 to 5 millimeters, is how thick each 2D image is when the computer cuts that 3D model into viewable slices. Think of the 3D model as a loaf of bread. The projections helped bake the loaf, and the slice thickness is how thick you cut each piece. You can have hundreds of slices from one scan.
Why do we need to cut the loaf of bread, though? We have our nice 3D image. Aren't we done there?
Haha, love the loaf analogy. You're right, we have a nice 3D model of the thorax after reconstructing those projections. But we cut the loaf into 2D slices because it's way easier for doctors to analyze. A full 3D model is cool, but radiologists typically work with 2D cross-sectional images to spot details like lung nodules, fractures, or fluid buildup. Each slice lets you focus on a specific layer of the
And
body.
when you say we cut it in a 5 millimeter slice thickness, where exactly do we see these 5 millimeters? Is it because we print it out?
No. The 5 millimeters slice thickness isn't about printing. It's about the depth of tissue each 2D CT image represents. When we say a slice is 5 millimeters thick, it means that 2D image shows a 5 millimeters deep section of the thorax, like a thin slab cut from that 3D model. On the screen, it looks flat, showing the structures within that 5 millimeters depth averaged together.
So inside those 5 millimeters, I will have a bunch of projections showed to me at the same time.
Not quite. Let's clear that up. Inside a 5 millimeter thick CT slice, you're not seeing a bunch of the original 2000 projections mashed together. Those projections were used to build the 3D model of the thorax. The 5 millimeter slice is a single 2D image cut from that 3D model, representing all the structures within that 5 millimeters of tissue.
And the doctor, which 5 millimeters do they choose?
Great question. The doctor doesn't manually pick which exact 5 millimeter section to view. Instead, the CT scanner and protocol determine how the thorax is divided into slices. For a thorax CT, the entire chest is scanned, and the computer automatically reconstructs the 3D model into a series of contiguous slices, each 5 millimeters thick or whatever thickness is set. These slices cover the whole thorax from top to bottom, so the doctor gets a stack of images, maybe 50 to 100 slices, depending on the chest's height. They scroll through all the slices on a monitor
to examine. So the slices are, when you say they're from top to bottom, what do you mean? So let's say I have 100 slices. How will tell me the first slide, how it will look, the 100th slide and the 50th?
All right, let's visualize this. For a thorax CT with 100 slices, each slice is a 2D cross-sectional image of the chest, typically 5 millimeters thick, moving from top to bottom, or sometimes bottom to top, depending on the setup. Here's how they look. First slice. This is at the top of the thorax, near the shoulders. It shows the upper lungs, the apexes we talked about, parts of the clavicles, and maybe some neck muscles. The lungs look mostly black, air, with some gray blood vessels and white bone. 50th slice. Roughly halfway down the chest, you're in the mid-thorax. This slice might show the heart. Gray, central, major blood vessels like the aorta, both lungs with branching vessels and parts of the ribs or spine. The lungs still look dark, but you see more complex structures. 100th slice, at the bottom of the thorax, near the diaphragm.
So we go from superior to inferior. We don't go from anterior to posterior slices. Is this superior to inferior called cross-sectional or transverse?
Yep, you got it. In a thorax CT, the slices typically go from superior, top, near the shoulders, to inferior, bottom, near the diaphragm, not anterior to posterior.
Why?
Good question. Thorax CT scans use transverse, axial, slices, going superior to inferior, because it aligns best with how the body is positioned in the scanner and how radiologists analyze anatomy. You're lying flat on your back, and the CT scanner rotates around you, taking X-ray data in a circular path. The easiest and most natural way to reconstruct this data is into horizontal slices, perpendicular to the long axis of your body. This transverse view shows key structures, like the lungs, heart, and major vessels, in a way that's intuitive for diagnosis, matching how anatomy is taught and studied. Other orientations, like coronal, front to back, or sagittal, side to side, can be reconstructed from the data, but they're less standard because transverse slices give a clear, systematic view of the thorax from top to bottom.
Okay, so let me ask about now primary pulmonary lobules, sinus, and secondary pulmonary lobules. What are these?
All right. Let's break down primary and secondary pulmonary lobules and their sinuses in the context of lung anatomy, keeping it tight. The primary pulmonary lobule is the smallest functional unit of the lung, made up of a terminal bronchiole, its branching respiratory bronchioles, alveolar ducts, and alveoli, where gas exchange happens. It's microscopic, not directly visible on imaging like CT, but it's the building block of lung tissue. The
So
secondary
the primary pulmonary nodules, a lot of primary ones make a secondary one.
Exactly, you're on it. A secondary pulmonary lobule is made up of roughly 30 to 50 primary pulmonary lobules. The primary lobule is the tiny, microscopic unit, terminal bronchiole, respiratory bronchioles, alveolar ducts, and alveoli. The secondary lobule is a larger, functional unit, about 1 to 2.5 centimeters in size, visible on high-resolution CT. It's defined by connective tissue septa and contains a central bronchiole and artery, surrounded by veins and lymphatics in the septa. No sinuses in lobules, but you might mean pleural spaces or airways. Want to dive into how these show up on CT or focus on something specific like imaging?
So we have the primary ones and the secondary ones, and what's the sinus? And also tell me the whole like from the smallest unit to the biggest and how they're connected and like what the function of which one is.
All right, let's map out the lung from the smallest unit to the biggest, including the sinus, and cover their functions and connections. I'll keep it concise. Alveolus, smallest unit, a tiny air sac where gas exchange, oxygen in, CO2 out, happens in microscopic secondary pulmonary lobules. Walls are super thin for diffusion, connected to alveolar ducts.
Wait, why alveoli? You said the smallest one was primary pulmonary lobules.
My bad. Let's clear that up. I didn't mean to say the alveolus is smaller than the primary pulmonary lobule. I was breaking it down to the smallest structural piece. The alveolus is the tiniest functional part, where gas exchange happens. But the primary pulmonary lobule is the smallest complete unit that includes a few alveoli, their alveolar ducts, and a respiratory bronchiole. Here's the corrected rundown, starting small and going big, including the sinus, with functions and connections. Alveolus, tiny air sac where oxygen and CO2 exchange with blood, connected to alveolar ducts. Alveolar ducts, tubes linking alveoli to respiratory bronchioles, move air to alveoli. A sinus, a cluster of alveoli, alveolar ducts, and one or more respiratory bronchioles. It's the basic gas exchange unit, smaller than a primary lobule. Primary pulmonary lobule includes one or more acini, so respiratory bronchioles, alveolar ducts, alveoli, fed by a terminal bronchiole, smallest complete functional unit, microscopic, handles gas exchange locally. Secondary pulmonary lobule, made of 30 to 50 primary lobules, about 1 to 2.5 centimeters, visible on CT, has a central bronchiole and artery, surrounded by veins and septa. Manages regional air distribution and exchange. Lobe. 5 lobes, 3 right, 2 left, each with thousands of secondary lobules, separated by fissures, handle large-scale air distribution. Whole lung. 2 lungs, each with lobes, connected via bronchi to the trachea.
Questions. So the secondary pulmonary lobules, how many do we have? And did you say we have connections with veins, one vein and one artery to each one of them?
All right, let's tackle your questions about secondary pulmonary lobules. Number of secondary pulmonary lobules. Each lung has roughly 30,000 to 50,000 secondary pulmonary lobules. The exact number varies by lung size and individual anatomy, but that's the ballpark. Vessels. Yes, each secondary lobule typically has one central artery, a branch of the pulmonary artery, that runs with the bronchiole, bringing blood to be oxygenated. The veins, however, are in the connective tissue septa surrounding the lobule, not central. One or more pulmonary veins drain oxygenated blood back toward the heart. Lymphatics also run in the septa.
Wait, so, okay. So we have one artery for each secondary lobule, but not one vein.
Yep, exactly. Each secondary pulmonary lobule has one central artery, paired with the bronchiole, delivering blood for oxygenation. The veins, though, aren't one per lobule. They run in the connective tissue septa around the lobule's edges, draining blood from multiple alveoli across adjacent lobules.
Why do we have less veins, and what's a connective tissue septum?
Good questions. Let's clear this up. Why fewer veins? We don't necessarily have fewer veins, but their arrangement differs from arteries in secondary pulmonary lobules. Each lobule has one central pulmonary artery branch, delivering blood precisely to its alveoli. Pulmonary veins, however, are in the interlobular septa, the connective tissue walls surrounding the lobule. These veins collect blood from multiple alveoli across adjacent lobules, so they're shared rather than one vein per lobule. This setup is efficient. Arteries target each lobule for oxygen delivery, while veins pool oxygenated blood from a slightly broader area, reducing the need for a dedicated vein per lobule. Connective tissue septa. This is a thin layer of fibrous tissue that forms the outer boundary of a secondary pulmonary lobule, like a wall separating it from neighboring lobules. It contains pulmonary veins, lymphatics, and some connective fibers, giving the lobule its polyhedral shape. Think 1 to 2.5 centimeter.
Bro, sorry to interrupt you, but I'm very confused with all of this.
No worries, bro. Let's hit pause and sort this out. I know the lung anatomy stuff can get wild. You're asking about secondary pulmonary lobules, veins, arteries, and connective tissue septa, and it sounds like it's piling up. Let's simplify. Secondary pulmonary lobule, a small lung unit, 1 to 2.5 centimeters, made of many tiny gas exchange zones. There are about 30,000 to 50,000 per lung. Artery. One artery goes to the center of each lobule, bringing blood to be oxygenated. Veins. These sit in the walls, septa, around the lobule, not in the center. They collect blood from multiple lobules, so it's not one vein per lobule, but a shared network. Connective tissue septa. The wall around each lobule, like a fence, holding veins and lymph vessels. It shows as thin lines on CT. Where's the confusion kicking in? Is it the vein
we have a system of veins in the walls, and I'm just wondering why the veins are in the walls, or these septa, and how many of these septa do we have? And I also wanted to ask about terminal bronchi and respiratory bronchi and how they connect.
All right, let's tackle this step by step, keeping it clear and concise. Why are veins in the septa? The pulmonary veins sit in the connective tissue septa, the walls around secondary pulmonary lobules, because it's an efficient design.
Fuck's sake, dude. Why are you making these... Guys, can you hear these robot noises it makes? It's really annoying me. iPhones. Fuck's sake. Hey, dude, why these? You've thrown ChatGPT at me right now. You're saying it's because it's efficient. Well, why is it efficient? Huh? Tell me in a sentence.
Dude, no ChatGPT vibes here. The veins are in the septa because it saves space, letting the lobule's core focus on
Hey,
air.
why don't we put arteries there to save space too?
Great question. Arteries aren't in the septa because they need to deliver blood directly to the center of each secondary pulmonary
Hey, why don't veins need to take blood away from each center?
Veins don't need to be in the center of each secondary pulmonary lobule because oxygenated blood from the alveoli can diffuse a short distance to the septa for collection. The central artery delivers blood
Well,
right
why
to
don't
the...
we have this diffusion with the arteries too? Just try to guess my next question each time you speak and just add it to what you're gonna say.
All right, I love the challenge. Let's dive in. The arteries can't rely on diffusion like veins because deoxygenated blood needs to be delivered precisely to the alveoli in the lobule's core for efficient gas exchange, while veins can collect oxygenated blood from a slightly wider area in the septa since diffusion works well over short distances post-oxygenation. The central artery, paired with the bronchiole, ensures blood gets to the alveoli fast and evenly, whereas veins in the septa can gather blood from multiple alveoli across adjacent lobules without needing to be so central. Guessing your next question. Why does the blood need to be delivered so precisely by arteries, but not collected as precisely by veins? If that's it, it's because the lungs prioritize getting deoxygenated blood to the alveoli for oxygen uptake, which needs tight targeting, while collecting oxygenated blood is less sensitive to exact positioning since it's already done its main job. If you meant something
All right,
else,
perfect. And you guessed correctly, yeah. So why is it less sensitive when it doesn't have oxygen?
nice. Glad I nailed the guess. All right, collecting oxygenated blood is less sensitive because, after gas exchange, the blood's job in the alveoli is done. It's already oxygen rich and ready to head back to the heart. The veins in the septa can efficiently gather this blood from a broader area since precise positioning isn't critical for just draining it away. Delivering deoxygenated blood, though, needs precision to hit the alveoli exactly for optimal oxygen pickup.
Okay.
Which is why.
And how could we obtain a picture of the distribution of ventilation in the lungs?
Awesome. Let's talk about imaging lung ventilation. To get a picture of ventilation distribution, how air moves in and out of the lungs, the go-to method is a ventilation perfusion VQ scan, specifically the ventilation part. You inhale a radioactive gas or aerosol like xenon 133 or technetium 99M, and a gamma camera captures how it spreads through the lungs, showing airflow patterns. Areas with good ventilation light up. Poorly ventilated areas, like in COPD or obstruction, stay dark. Another option is high-resolution CT with inhaled contrast, like xenon-enhanced CT, which maps ventilation dynamically. MRI with hyperpolarized gases, helium-3 or xenon 129, is newer, offering detailed 3D ventilation maps without radiation.
Wait, so
but it's
we
less-
use a radioactive gas like xenon or krypton or radioactive aerosol to do what?
My bad for not clarifying. In a ventilation scan, you inhale a radioactive gas like xenon 133 or a radioactive aerosol like technetium 99M labeled particles to map how air flows into your lungs.
Because
gamma-
we will see the particle moving.
Nah, you don't directly see the particles moving, like a video of them zooming through the lungs. When you inhale a radioactive gas like xenon 133 or an aerosol like technetium 99M in a ventilation scan, the gamma camera captures the radiation they emit. This creates a static or semi-dynamic image showing where the particles end up in the lungs at a given moment. Well-ventilated areas light up because the radioactive stuff reaches them, while poorly ventilated spots stay dark. Some advanced scans can take sequential...
So you're saying that we take a picture and we see where it ended up?
Yup, exactly. In a ventilation scan, you inhale a radioactive gas or aerosol, and the gamma camera takes a picture that shows where the radioactive stuff ended up in your lungs. Bright areas mean good ventilation, where the particles reached, and dark areas show poor ventilation.
And do we have to keep track of time here?
Good catch. Time does play a role in ventilation scans, but not in a super complicated way. When you inhale the radioactive gas like xenon 133 or aerosol like technetium 99M, the gamma camera takes images at specific moments to capture how the particles distribute in the lungs. For xenon, images might be snapped during a single breath or over a few seconds as it washes in and out, showing ventilation patterns.
I'm just a bit confused regarding this because, basically, I'm a bit confused because I would have thought that if we take a long time, the particle will go further or something.
Totally get the confusion. Let's clear it up. You're right to think time could affect how far the radioactive particles go in a ventilation scan. But here's the deal. The imaging is timed to capture a specific moment of distribution, not to track particles wandering over a long period. When you inhale a radioactive gas like xenon 133, it spreads quickly through ventilated lung areas during a single breath or a few seconds. The gamma camera snaps images right then, showing where the gas ended up.
I don't get it, bro.
No worries, bro. Let's make this crystal clear. You're confused about how time fits into ventilation scans and why the radioactive particles don't just keep spreading. Here's the deal. When you inhale something like xenon 133 gas for a ventilation scan, it moves fast into the lungs' air spaces during one breath or a few seconds. The gamma camera takes a quick picture at that moment, showing where the gas landed.
Again, I'm confused.
Alright, bro. My bad for not nailing the explanation. Let's break it down super simple. You're wondering about the ventilation scan and how we image those radioactive particles without them spreading too far. When you breathe in the radioactive gas, like xenon 133, it hits the lungs fast, in one breath. The gamma camera snaps a picture right then, catching where the gas is, like a photo of which lung parts got air. Dark spots mean poorly ventilated areas. If that's confusing you, let me know which parts still confuse you.
So,
and I'll try.
Because it's in one breath, we don't really care, basically. But how will the results show us about ventilation?
Exactly. You got it. Since the radioactive gas, like xenon 133, spreads in one breath, we capture the image fast, so we don't worry about it moving too far. The results show ventilation by highlighting which parts of the lungs got the gas. On the gamma camera image, bright areas mean good ventilation.
I see what you mean. I see. So the brighter, the better.
Yep, you nailed it. In a ventilation scan, brighter is better. Bright spots on the image mean the radioactive gas reached those lung areas easily, showing good ventilation. Darker spots mean less gas got there, pointing to poor ventilation, like in blockages or diseases.
Okay, let me ask you about airspace shadowing and consolidation. What is this?
Alright, let's dive into airspace shadowing and consolidation. In lung imaging, like on a chest X-ray or CT, airspace shadowing, also called airspace opacification, happens when the normally air-filled alveoli fill with something else, liquid, pus, blood, or cells. This makes the lung look cloudy or white instead of dark, since air is black on X-rays. Consolidation is a specific type of airspace shadowing where the alveoli are filled with fluid, pus, like in pneumonia, or other material, but the lung structure stays intact. It shows up as a solid, white patch on imaging, often with sharp borders.
And it might be transudate too. What is transudate?
Good catch. Yes, consolidation can involve transudate. A transudate is a clear fluid that leaks into the alveoli due to increased pressure in blood vessels.
And what is the difference between that and exudate?
Alright, let's break it down. A transudate is a clear, low-protein fluid that leaks into the alveoli due to increased pressure, like in heart failure or low blood protein, e.g. in kidney issues. It's caused by mechanical forces, not inflammation. An exudate, on the other hand, is a thick, protein-rich fluid full of cells, pus, or debris caused by inflammation or infection, like in pneumonia or lung injury. On imaging, both can cause consolidation, but exudates often look denser and may show up with other signs like thickened septa. Guessing your next question. How do we tell transudate from exudate on a CT scan? If that's it, CT can't directly distinguish them, but context, e.g., heart failure for transudate, fever for exudate, and patterns.
To be honest, I was still kind of confused about the difference between transudate and exudate. So if you could tell me again that in a sentence.
Transudate is a clear, low-protein fluid leaking into alveoli due to pressure changes, like in heart failure, while exudate is a thick, protein-rich fluid with cells caused by inflammation or infection, like in pneumonia.
One more
Guessing?
time.
Transudate is clear, low-protein fluid leaking into alveoli from pressure issues like heart failure, while exudate is thick, protein-rich fluid with cells from inflammation or infection, like pneumonia.
How does their name relate to these structural and functional?
Guessing your next question.
Hey!
How do doctors figure out if it's transudate or exudate in the lungs?
Dude. Oh, guys. Sorry.
If that's it,
I was a bit of a Karen.
they use clinical clues.
But, dude, isn't it so weird, guys? I'm so, like, authoritarian towards Grok. I'm not like this in real life, I promise, guys. Okay. So, dude, how does the name transudate and exudate, how do they relate to these structural and functional differences? Answer to me in specifically one sentence, please.
The names transudate and exudate reflect the structural and functional differences. Transudate, from trans, across, is thin fluid crossing vessels due to pressure, while exudate, from ex, out, is thick fluid oozing out due to inflammation.
So why out means thick?
Good catch. I wasn't clear enough. The X in exudate doesn't directly mean thick. It comes from Latin for out or oozing out.
Yes, and I'm saying, why does out mean thick?
My bad for the mix-up. The X in exudate, meaning out or oozing out from Latin, doesn't itself mean thick. It just describes the process where inflammatory damage causes blood vessels to leak thick, protein-rich fluid with cells, unlike the thin fluid of
And why does
transudate.
going out means that there's going to be thick and not thin plasma or whatever?
All right, let's nail this down. The X in exudate means out or oozing out, but the thickness comes from why the fluid leaks. Inflammation damages blood vessels, making them leaky, so not just thin plasma escapes, but also proteins, cells, and debris, creating a thick, gooey fluid.
I see, that makes sense. Perfect. Okay. So I can see here a ventilation and perfusion scan. I don't understand what it means though. Can you explain to me what I'm looking at?
Cool. Let's break down a ventilation and perfusion VQ scan. You're looking at two sets of images. One for ventilation, how air moves in the lungs, and one for perfusion, how blood flows through lung vessels. For ventilation, you inhale a radioactive gas like xenon 133 or an aerosol, and a gamma camera shows where the air goes. Bright areas mean good airflow. Dark areas mean poor ventilation, like in COPD. For perfusion, you get an injection of a radioactive tracer, like technetium-99m, and the camera shows blood flow. Bright for good flow, dark for low flow, like in a pulmonary embolism. The images are compared to spot mismatches. Normal
So
lungs
they have to look similar basically to have a good VQ ratio.
Exactly. In a healthy lung, the ventilation and perfusion images should look similar, both showing bright, even patterns across the lungs.
I see. So how could we produce a steady state image of lung blood flow?
To produce a steady state image of lung blood flow, you typically use the perfusion part of a ventilation perfusion VQ scan. A radioactive tracer, like technetium-99m labeled macroaggregated albumin, is injected into a vein, travels to the lungs, and gets temporarily trapped in the pulmonary capillaries. A gamma camera then captures a snapshot of where the tracer distributes, creating a steady-state image where bright areas show good blood flow and dark areas indicate reduced flow, like in pulmonary embolism. This image reflects blood flow at the moment of imaging, stabilized by the tracer's brief lodging in vessels. Guessing your next question, how accurate is this image for diagnosing lung blood flow issues? If so, it's very reliable for detecting conditions like pulmonary embolism, especially when paired with ventilation images, though CT pulmonary angiography is often preferred for precision. What's next?
Broski, I didn't understand your answer. I'll be honest, I didn't even understand my question.
Haha, no sweat, broski. Let's reset. Your question was about getting a steady-state image of lung blood flow, which just means a clear snapshot of how blood is flowing through the lungs at one moment. Here's the simple version. You inject a tiny amount of radioactive stuff, like technetium-99m, into a vein. It zips to the lungs, gets stuck in the small blood vessels for a bit, and a special camera takes a picture. Bright spots show where blood is flowing well.
I see. So with the lung perfusion, we have a bunch of intravenous particles. Can you explain this? And what is a macroaggregated human serum albumin?
All right, let's break it down. In a lung perfusion scan, intravenous particles are used to map blood flow. Specifically, you get a small injection of a radioactive tracer called technetium-99m, labeled macroaggregated albumin, MAA. Here's what that is. Macroaggregated albumin,
And
MAA.
what patient posture would achieve the most uniform distribution of particles throughout the lungs?
To achieve the most uniform distribution of particles, like technetium-99m macroaggregated albumin, MAA, during a lung perfusion scan, the patient should be in a supine position, lying flat on their back. This posture allows gravity to distribute blood flow, and thus the injected particles more evenly across both lungs.
But wouldn't they be more posteriorly?
You're right to question that. Good catch. In the supine position, lying flat on the back, gravity can cause slightly more blood flow to the posterior, lower parts of the lungs, since they're dependent in that posture. However, this effect is minimal compared to upright or seated positions,
Okay,
where gravity...
got it. Guys, I'm going to take a small break and we'll be back with part 2 of the episode, pleural and chest wall disease. Let's go, I'm back from my break, to part 2, pleural and chest wall disease. So, let's start with a nice simple question. What are the pleura?
All right, welcome back. Let's dive into pleural and chest wall disease with your question. The pleura are thin, double-layered membranes surrounding the lungs. The visceral pleura covers the lung surface, and the parietal pleura lines the chest wall, diaphragm, and mediastinum. Between them is a tiny space with fluid that lets the lungs slide smoothly during breathing. Guessing your next question, what happens when something goes wrong with the pleura? If so, issues like fluid buildup, pleural effusion, air in the space, pneumothorax, or inflammation, pleuritis, can cause pain or breathing trouble, visible on X-rays or CT. What's next?
Okay. So, what's the mesothelium and what does it have to do with the pleura?
The mesothelium is a single layer of flat cells that lines the pleura, forming both the visceral and parietal pleural surfaces. It produces the thin film of fluid in the pleural space, which lubricates the lungs for smooth movement during breathing.
One more time, please.
No prob. The mesothelium is a thin layer of cells that forms the surface of both the visceral and parietal pleura, secreting fluid to lubricate the pleural space for easy lung movement and serving as a protective lining. Guessing your next question, how does the mesothelium get affected in pleural diseases? If so, it can become inflamed, pleuritis, thicken pleural fibrosis, or develop cancer, mesothelioma, often linked to asbestos exposure, and these show up on CT or X-ray.
I don't understand what you're talking about.
My bad. Let's simplify. The mesothelium is like a super thin skin made of cells that covers the pleura, the membranes around your lungs. It makes a tiny bit of slippery fluid so your lungs can slide without friction when you breathe, and it protects the pleura.
This is the mesothelium?
Yup, you got it. The mesothelium is that thin layer of cells covering the pleura, acting like a slick coating that makes fluid to help the lungs move smoothly and protects the pleural membranes.
Why is it called mesothelium?
Good question. The name mesothelium comes from its embryonic origins and structure. Meso means middle in Greek, referring to its development from the mesoderm, the middle layer of embryonic tissue that forms many body linings. Thelium refers to its cell type, a flat, protective layer. So, mesothelium is the special epithelial lining from the mesoderm that coats the pleura, producing fluid for lung movement.
Brother,
Guessing
I'm
your
so sorry, but I still don't understand, to be honest.
No worries, bro. Let's make this super clear. The mesothelium is called that because it's a thin layer of cells that comes from the middle layer of tissue when you're forming as an embryo, and it acts like a protective, slippery skin on the pleura
And what
around
is
your lung.
is it between the visceral and the parietal pleura?
You're honing in on it. The mesothelium isn't between the visceral and parietal pleura. It's the actual surface layer of cells on both the visceral pleura, covering the lungs, and the parietal pleura.
So the surface of the cells that lines both pleura is called mesothelium?
Exactly, you nailed it. The mesothelium is the layer of cells that forms the surface of both the visceral pleura on the lungs and the parietal pleura on the chest wall, making fluid to keep things slippery. Guessing your next question. How does this mesothelium...
That makes sense. And how does pleural effusion connect with pleura?
Cool. Glad that clicked. A pleural effusion is when extra fluid builds up in the pleural space, the thin gap between the visceral pleura, covering the lungs, and parietal pleura, lining the chest wall. Normally, the mesothelium keeps just a tiny bit of fluid there for lubrication, but in conditions like heart failure, infection, or cancer, too much fluid, transudate or exudate, collects, pressing on the lungs and causing breathing issues. On X-ray or CT, it shows as a white area, often blunting the lung's sharp angles. Guessing your next question, what causes pleural effusion to form?
Yes. What causes it? And as images, how we will see it if we take an X-ray? How will it be more white, more black?
All right, let's dive into pleural effusion causes and how it looks on an X-ray. Causes. Pleural effusion happens when excess fluid collects in the pleural space due to transudates from pressure imbalances, e.g., heart failure, kidney disease. Exudates from inflammation or damage, e.g., pneumonia, cancer, tuberculosis, or other issues like trauma or pulmonary embolism. X-ray appearance. On a chest X-ray, pleural effusion typically looks white or gray because the fluid blocks X-rays more than air-filled lungs, which are black. It often appears as a smooth, curved white area at the lung's base, blunting the sharp costophrenic angle, or can layer along the side of the chest if the patient is upright. Large effusions may push the lung or shift the mediastinum. Guessing your next question.
Can you tell me one more time? I didn't quite catch this.
No prob. Let's go over it again. Pleural effusion is extra fluid in the pleural space between the visceral and parietal pleura, caused by things like heart failure, transudate, pneumonia, cancer, or TB, exudate, or trauma. On a chest X-ray, It shows up as white or gray because the fluid blocks X rays, unlike the black, air filled lungs, often looking like a smooth, curved patch at the lung base or along the chest wall, blunting sharp angles. Guessing your next question: how do we know if the effusion is serious? If so,
No, actually, so we talked about it before. So transudate means we go through, whereas exudate means it's going to be thick because we have these, it goes out and we get these proteins out too and everything, right?
yup, you got it. Transudate is thin, clear fluid that leaks into the pleural space due to pressure changes, like in heart failure, while exudate is thick, protein-rich fluid with cells that oozes out because of inflammation or damage, like in pneumonia or cancer. That's why pleural effusions can be either type, depending on the cause.
Okay, let's focus a bit on transudative effusions.
All right, let's zoom in on transudative pleural effusions. These are when thin, clear fluid builds up in the pleural space due to increased pressure or low protein levels in blood vessels, not inflammation. Common causes
for
include heart
instance,
failure.
LVF, is this transudative?
Yep, exactly. LVF, or left ventricular failure, heart failure where the left side of the heart struggles, typically causes a transudative pleural effusion. The increased pressure in the heart and lungs pushes thin, clear fluid into the pleural space. On an X-ray, it often shows as white patches, usually on both sides, blunting the lung bases. Guessing your next question: how do we confirm it's transudative and not exudative?
What
If
is
so,
LVF?
all right, let's clarify with LVF, left ventricular failure. In LVF, the left ventricle doesn't pump blood effectively, causing pressure to back up into the lungs' blood vessels. This high pressure pushes thin, clear fluid, a transudate, into the pleural space, leading to a transudative pleural effusion. On a chest X-ray, it typically appears as white or gray areas, often bilateral, blunting the lung bases, sometimes with other signs like pulmonary edema. Guessing your next question: how do we distinguish LVF-related effusion from other causes on imaging? If so, bilateral effusions, cardiomegaly, and pulmonary edema on X-ray or CT strongly suggest LVF, but fluid analysis confirms it's transudative. What's next?
So why is left ventricular failure? So left ventricular failure means that we will have fluid accumulation in the lungs. But why is this transudative?
Good question. Left ventricular failure, LVF, causes fluid accumulation in the lungs because the left ventricle can't pump blood out effectively, so pressure builds up in the pulmonary veins and capillaries. This high pressure forces thin, clear fluid, mostly plasma, out of the blood vessels into the pleural space or alveoli, forming a transudative effusion. It's transudative because there's no inflammation or vessel damage, just mechanical pressure pushing fluid across intact vessel walls, unlike exudates, which involve inflammatory leaks. Guessing your next question.
Okay, so I get it. And what about the telectasis?
Nice. Glad it's clicking. Atelectasis is when part or all of a lung collapses or doesn't inflate properly, leading to reduced or no air in the affected alveoli. It's not a pleural effusion, but it can be related to pleural issues. Causes include airway blockage, like mucus or a tumor, compression, e.g., from a pleural effusion pushing on the lung, or surgery-related loss of lung expansion. On a chest X-ray or CT, atelectasis looks white or gray, since airless lung tissue blocks X-rays, often with a sharp edge, shifted structures like the mediastinum.
What is, wait, simply in a sentence, what is atelectasis?
Atelectasis is when a part or all of a lung collapses or fails to inflate, causing reduced or no air in the alveoli. Your next question.
And atelectasis, why is transudate? And what is the etymology of atelectasis?
All right, let's tackle both questions in one go. Why is atelectasis transudative? Atelectasis itself isn't transudative or exudative because it's not about fluid buildup. It's the collapse or failure of the lung to inflate, causing airless alveoli. However, if atelectasis is caused by a transudative pleural effusion, like from heart failure compressing the lung, the effusion is transudative, not the atelectasis.
Why? Why is the effusion transudative if it's due to atelectasis?
My bad. I think I confused things. Atelectasis itself doesn't cause a pleural effusion, transudative or otherwise. It's the lung collapse or failure to inflate due to something like airway blockage or external pressure. If a transudative pleural effusion, like from heart failure, is present, it can compress the lung and cause atelectasis, but the effusion is transudative because of the underlying condition.
Yes,
e.g.
so why would a pleural effusion that is transudative cause atelectasis? Why wouldn't an exudative effusion cause the atelectasis?
Great question. Both transudative and exudative pleural effusions can cause atelectasis, but let's clarify why a transudative one might. A transudative pleural effusion, like from heart failure, builds up thin fluid in the pleural space due to pressure imbalances. This fluid can compress the lung, reducing its ability to expand and causing atelectasis, lung collapse. An exudative effusion, like from pneumonia or cancer, can also compress the lung and cause atelectasis in the same way by physically pressing on it.
I don't get it, bro. I don't get it.
My bad, bro. Let's make it super simple. A transudative pleural effusion, thin fluid from something like heart failure, can cause atelectasis because the extra fluid in the pleural space squishes the lung, making it collapse. An exudative effusion, thick fluid from infection or cancer, can also cause atelectasis the same way by pressing on the lung. Both types of effusion can lead to lung collapse if there's enough fluid. It's not about the fluid.
I see. So there's no hole, basically. There should be a hole if it's exudative.
I see where you're going, but let's clear up the whole thing. Neither transudative nor exudative pleural effusions involve a hole in the lung or pleura. They're both about fluid building up in the pleural space, pressing on the lung to cause atelectasis, collapse. Transudative effusions, thin from heart failure, and exudative effusions, thick from infection or cancer, both just add pressure that squishes the lung, no holes needed. Maybe you're thinking of something like a pneumothorax.
I thought exudative meant that there's like a hole and a lot of thick blood comes out.
Oh, gotcha. I see the mix-up. No worries, let's clear it up. Exudative pleural effusion doesn't mean there's a hole or blood pouring out. It means thick, protein-rich fluid, not necessarily blood, leaks into the pleural space because of inflammation or damage.
Yes,
like
but exactly. But the thing that makes it... What is the reason that it's thick and not thin?
The reason an exudative pleural effusion is thick is that inflammation or damage, like from pneumonia or cancer, makes blood vessels leaky, letting proteins, cells, and sometimes pus or debris escape into the pleural space. Unlike a transudative effusion, where only thin, clear plasma leaks due to pressure without vessel damage.
So exudative has vessel damage too.
Yup,
Yeah,
you got it.
so that vessel damage allows for bigger molecules to go out.
Exactly.
So
You're on
basically,
it.
the problem is that I've used the word whole. It's not whole. Well, what kind of damage is it? Is it a damage that makes things more permeable?
You're spot on. And I
Okay.
love how sweet
Alrighty,
we're rolling.
I'm back and
So
I'm
we
strong,
cleared up that
guys.
exudative
And
effusion.
let's talk about cirrhotic liver disease and why it's a transsudative effusion, how it relates to it anyway.
All right, let's dive into how cirrhotic liver disease causes transudative pleural effusion. Liver cirrhosis scars the liver, messing with blood flow and protein production. This leads to two key issues: portal hypertension, high pressure in liver veins, and low blood albumin, a protein. The high pressure pushes fluid out of vessels, and low albumin reduces the ability to keep fluid in. So thin, clear fluid, transuded, leaks into body cavities, including the pleural space, often as a right-sided effusion called hepatic hydrothorax. On X-ray or CT,
Could you summarize it in a few words because I don't get it?
Cirrhosis causes transudative pleural effusion by high liver vein pressure and low blood protein, leaking thin fluid into the pleural space.
Okay, I see.
Yes.
What about hypoalbuminemia and peritoneal dialysis?
All right, let's break down hypoalbuminemia and dialysis in relation to transudative pleural effusion, keeping it concise. Hypoalbuminemia. This is low blood albumin, a protein that helps keep fluid in blood vessels. When albumin is low, exe from liver disease, malnutrition, or kidney issues, fluid leaks out into spaces like the pleural cavity, causing a transudative pleural effusion. It's transudative because it's thin, clear fluid due to pressure imbalances, not inflammation. Peritoneal dialysis. This can also lead to transudative pleural effusion, often as a complication called hydrothorax. Dialysis fluid in the peritoneal cavity increases abdominal pressure, which can push fluid through small defects in the diaphragm.
I see. And inflammation then is more in exudative.
Yep, exactly. Inflammation is the key driver in exudative pleural effusions, causing blood vessels to become leaky, letting thick, protein-rich fluid with cells like pus
Why
or
does
debris.
inflammation make the vessels leaky?
Inflammation makes vessels leaky because it triggers the release of chemicals, like cytokines and histamines, that widen gaps between endothelial cells and blood vessel walls.
How do
allowing
cytokines do this?
Cytokines, small proteins released during inflammation, make blood vessels leaky by signaling endothelial cells in vessel walls to loosen their tight junctions, creating gaps that let proteins, cells, and fluid leak out into the pleural space.
But how do cytokines do this?
Cytokines make blood vessels leaky by binding to receptors on endothelial cells in vessel walls, triggering signals that loosen tight junctions between the cells and increase permeability, allowing proteins, cells, and fluid to escape into the pleural space, creating an exudative effusion. Guessing your next question? What specific cytokines are involved in this process? If so, key ones like TNF-alpha, IL-1, and IL-6 are major players, as they amplify inflammation and vessel permeability. What's next?
Okay, I'm going to come back to this, but I just want to ask you about chest wall disease. I want to understand the difference between kyphosis and scoliosis and pectus excavatum.
All right, let's dive into chest wall diseases and compare kyphosis, scoliosis, and pectus excavatum. Kyphosis. This is an excessive forward curve of the upper spine, thoracic region, often called hunchback. It can result from poor posture, osteoporosis, or congenital issues, potentially compressing the chest cavity and affecting lung expansion. On X-ray, you see an exaggerated spinal curve from the side. Scoliosis. This is a sideways S or C-shaped curve of the spine, often in the thoracic or lumbar regions. It can be idiopathic, unknown cause, congenital, or due to neuromuscular conditions. It may distort the chest wall, reducing lung capacity.
So
It shows
scoliosis is like a worm, but kyphosis, how does the name relate to the structural situation?
Good call. I like the worm analogy for scoliosis. The name kyphosis relates to its structure. It comes from the Greek word kyphos, meaning hump or bent. It describes the excessive forward curvature of the upper spine, creating a hunchback appearance that compresses the chest.
So shoulders will look backwards or shoulders will look forwards?
In kyphosis, the shoulders tend to look forward and inward because the excessive forward curve of the upper spine, thoracic region, creates a hunchback posture, pulling the shoulders anteriorly
Broski, do you bend forward or backward?
Got it. You're asking about the direction of the bend in kyphosis. In kyphosis, you bend forward, the upper spine curves excessively outward, posteriorly, creating a hunchback where the shoulders and head tilt forward.
I see. I see.
Sweet. Glad it's coming together. So, kyphosis has that forward hunchback bend, while scoliosis is the sideways worm-like curve, and pectus excavatum is the sunken chest. Guessing your next question, how do these conditions affect lung function or show up on imaging?
No, I'm going to go back to the exudative, actually. So, we have a few different ones. So, pulmonary embolism can be transudative or exudative.
All right, bro. Let's swing back to exudative effusions and clarify pulmonary embolism. A pleural effusion caused by a pulmonary embolism, PE, is typically exudative, not transudative. Here's why. PE blocks a lung artery, causing inflammation or tissue damage downstream, which makes blood vessels...
Yeah, but 8 to 9 times out of 10 it's exudative, but sometimes it's transudative.
You're right. I should have been clearer. Pulmonary embolism, PE, usually causes an exudative pleural effusion, about 80-90% of cases, due to inflammation or tissue damage making vessels leaky with protein-rich fluid. However, in rare cases, 1 to 2 out of 10, it can be transudative, often linked to conditions like heart failure or low protein states, exa hypoalbuminemia, that coincidentally occur with PE, where high pressure pushes thin fluid into the pleural space instead.
So basically, it will cause inflammation, and that tells us that it's exudative, right? Because of the cytokines creating this gap between endothelial cells.
Spot on. In pulmonary embolism, the blocked artery often triggers inflammation, releasing cytokines that widen gaps between endothelial cells and blood vessels, letting protein-rich fluid leak into the pleural space, making the effusion exudative. That's the main reason it's usually exudative.
What about malignancy?
Nice one. Pleural effusions caused by malignancy, cancer, are typically exudative. Tumors, like lung cancer or metastatic cancers, exa, breast cancer in the pleura, cause inflammation or directly invade the pleural space, making blood vessels leaky. This lets protein-rich fluid, cells, and sometimes blood escape, forming an exudative effusion. On rare occasions, a transudative effusion might occur if the malignancy causes secondary issues like heart failure or hypoalbuminemia.
So it's exudative because, okay. What about tuberculosis?
Yup. Pleural effusions caused by tuberculosis, TB, are also typically exudative. TB infection in the lungs or pleura triggers a strong inflammatory response, releasing cytokines that make blood vessels leaky, allowing protein-rich fluid, immune cells, and sometimes pus to collect in the pleural space.
And how will a pleural effusion show as an image?
Pleural effusion on imaging, like a chest X-ray or CT, shows up as a white or gray area because the fluid blocks X-rays more than air-filled lungs, which are black. On an X-ray, it typically appears as a smooth, curved white patch at the lung base, often blunting the sharp costophrenic angle or layering along the chest wall if upright. On CT, it's clearer, showing fluid as a homogeneous gray area in the pleural space, sometimes with signs like thickened pleura if exudative. Exe from TB or malignancy. Guessing your next question.
No. Tell me again, to be honest, I didn't understand.
No worries, let's go over it again. A pleural effusion on a chest X-ray or CT looks white or gray because the fluid stops X-rays more than the air-filled lungs, which are black.
Yes, that makes sense. Okay, and let's talk a bit about the difference on hemothorax and pneumothorax. So hemothorax is blood in the thorax, right?
Yep, you're on the right track. Let's break down hemothorax and pneumothorax. Hemothorax. This is when blood collects in the pleural space between the visceral and parietal pleura, usually due to trauma, surgery, or sometimes conditions like cancer or a ruptured vessel. It looks white or gray on a chest X-ray or CT, similar to a pleural effusion, but denser, and may layer out if the patient is upright. CT can confirm its blood by measuring its density, Hounsfield units. Pneumothorax. This is when air gets into the pleural space, often from a lung puncture, trauma, or spontaneous rupture, like in COPD. It causes lung collapse and shows as a black, air-filled area on X-ray or CT, with no lung markings, often with a sharp lung edge. Unlike hemothorax, it's air, not blood. Both can cause breathing issues, but hemothorax adds blood loss risks. Guessing your next question, how do we tell hemothorax from pneumothorax on imaging? If so, hemothorax is white-gray and fluid-like on X-ray CT, while pneumothorax is black with a collapsed lung edge. CT confirms the difference. What's next?
Well, I want to understand a bit about the primary spontaneous and secondary spontaneous pneumothorax. And how does the air go inside this pleural space?
All right, let's dive into primary spontaneous pneumothorax, PSP, secondary spontaneous pneumothorax, SSP, and how air gets into the pleural space. Primary spontaneous pneumothorax, PSP. This happens in healthy people, usually young, tall, thin males, without obvious lung disease. It's often caused by small blebs, air-filled sacs, on the lung surface, especially at the apex, that rupture, letting air leak into the pleural space. Secondary spontaneous pneumothorax, SSP. This occurs in people with underlying lung diseases like COPD, cystic fibrosis, or TB. Diseased lung tissue is weaker, so blebs,
Wait, these air-filled sacs that rupture in primary, why do they rupture? What caused them to rupture?
Good question. In primary spontaneous pneumothorax, PSP, the air-filled sacs, called blebs or bullae, on the lung surface, often at the apex, rupture because they're weak, thin-walled structures that can burst under stress. The exact cause isn't always clear, but factors like sudden pressure changes in the chest, exe, coughing, sneezing, or physical exertion, smoking, or even congenital weaknesses in the lung tissue can make them prone to breaking. When they pop, air escapes from the lung into the pleural space, causing the lung to collapse. Guessing your next question, why do some people get these blebs in the first place? If so, blebs are thought to form due to genetic factors, rapid lung growth during puberty, common in tall, thin males, or minor developmental flaws.
Tell me again in a few words why they rupture.
Blebs rupture in primary spontaneous pneumothorax due to weak walls and stress from coughing, exertion, or pressure changes. Guessing your next question.
Where do these pressure and coughing come from?
All right, let's zoom in. The Blebs and primary spontaneous pneumothorax rupture because their thin walls can't handle sudden increases in pressure inside the chest. This pressure can come from coughing or sneezing. These create rapid, forceful air movements in the lungs, spiking pressure against the blebs. Physical exertion. Activities like lifting or straining raise chest pressure by tensing muscles or changing breathing patterns. Spontaneous changes. Even without clear triggers.
Thank you for watching this episode, guys. Peace. So, let's try to understand a bit more the mitochondria myopathies. I don't understand what myopathies means, to be honest. So you have LHON, MERRF, MELAS, and KSS. What are these?
All right, let's clarify mitochondrial myopathies and those acronyms, keeping it tight. Myopathies are muscle diseases causing weakness, pain, or dysfunction. Mitochondrial myopathies are caused by mitochondrial DNA, mitochondrial mtDNA, or nuclear DNA mutations that impair ATP production via the electron transport chain, ETC, hitting high-energy tissues like muscles and nerves hardest. Now, those abbreviations. LHON, Leber hereditary optic neuropathy, affects vision, causing optic nerve damage due to mtDNA mutations in ETC genes. MERRF, myoclonic epilepsy with ragged red fibers, involves seizures, muscle jerks, and weak muscles with abnormal mitochondria, ragged red fibers from mtDNA tRNA mutations. MELAS, mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes, causes stroke-like brain issues, muscle weakness, and lactic acidosis due to mtDNA mutations like M3243AGG. KSS, Cairns-Sayre syndrome, features eye muscle paralysis, heart issues, and pigmentary retinopathy from large mtDNA deletions. All reduce ATP, disrupting muscle and nerve function. Clear? Want details on one condition or...
Okay, yeah, I want to understand the treatments a bit. Yeah, vitamin therapies, occupational therapies. Yeah.
All right, let's dive into treatments for mitochondrial myopathies like LHON, MERRF, MELAS, and KSS, with a focus on any notable Italian contributions, keeping it concise. There's no cure, but treatments aim to boost ATP production, manage symptoms, or slow progression. For LHON, edabenone, raxone, a synthetic coenzyme Q10 analog, is EMA approved. It enhances electron transport chain ETC function, improving vision in some patients with mutations like M1778GA, especially if treated early, over 24 months. Italian research has advanced LHON
Sir, I didn't ask about Italian research. I don't know where you got the word Italian from. You confused it with something else. I said vitamin therapy, and I also want to ask you about IVF strategy to replace defective mitochondria, and merging DNA from two eggs, and mitochondrial gene replacements, and maternal spindle transfer as alternative strategies. Can you tell me these two?
My bad. I misheard Italian for vitamin. Let's clarify treatments for mitochondrial myopathies, focusing on vitamin therapy and IVF strategies for defective mitochondria, keeping it concise. Vitamin therapy. Vitamins and coenzymes like coenzyme Q10, ubiquinone, riboflavin, vitamin B2, and L-carnitine are used to support mitochondrial function. CoQ10 enhances electron transport chain ETC efficiency, boosting ATP production in disorders like MELAS or KSS. Riboflavin aids ETC enzyme activity, helping in MERRF, while L-carnitine supports fatty acid transport for energy. These don't cure, but may reduce symptoms like muscle weakness. Evidence is mixed, with benefits varying by patient and mutation. IVF strategies for mitochondrial replacement. To prevent passing defective mtDNA, mitochondrial replacement therapy, MRT, swaps out faulty mitochondria. Two key techniques. 1. Maternal spindle transfer, MST. The nuclear DNA, spindle chromosome complex from a mother's egg with mutant mtDNA, is transferred to a donor egg with healthy mtDNA, which has had its nucleus removed. The reconstructed egg is fertilized, ensuring the child inherits the mother's nuclear DNA, but healthy donor mtDNA, reducing disease risk. 2. Pronuclear transfer, PNT. Similar, but done post-fertilization. The pronuclei, nuclear DNA, from a fertilized egg with mutant mtDNA are moved to a donor fertilized egg with healthy mtDNA, which has its pronuclei removed. This also ensures healthy mitochondria in the embryo. Merging DNA from two eggs refers to these MRT methods, combining the mother's nuclear DNA with a donor's mtDNA. These strategies aim to prevent mtDNA diseases like MELIS or LHON, though ethical concerns and variable mtDNA carryover, 102% maternal mtDNA, are challenges. Other alternatives like polar body transfer are less common. Clear? Want details on one method or vitamin specifics?
No, that makes sense. Okay, well, thank you so much for watching, guys, and I hope you have a wonderful rest of your day.